Hello everyone. Today we discuss placenta previa, a very common condition. We know that for every 210 pregnancies you find one placenta previa. So placenta previa is really a common condition. It's really a common cause of morbidity and mortality in our setup. And so we decided that we discuss the management of placenta previa today. So, as usual, we start with definitions. So, what is placenta previa? So, placenta previa is a placenta that is lying in the lower uterine segment and covering the os. And we say the placenta is covering the os if it's within 2 centimeters of the internal os. So if the placenta is more than 2 centimeters away from the internal os, we call that a low-lying placenta and not a placenta previa. In our setup, there's another situation where we say this is a low-lying placenta and not a placenta previa. This is a situation where we have a pregnancy that is below 28 weeks, which is the age of fetal viability in our setup. And so if someone has a placenta that is in the lower uterine segment and it is covering the os and it's below 28 weeks, we generally call that a low-lying placenta and not a placenta previa. And I think that is not very bad because we know the lower uterine segment gets formed between 26 and 32 weeks, and so we have time. Most of these low-lying placentas at this gestation age, 90% of them actually migrate, as people would put it. They move up and they don't become, they cease to be placenta previas. So if you repeat your scan at 32 weeks, 90% of these placenta previas are not in the lower uterine segment anymore. And you can repeat these scans at 36 weeks again, and you find that even more placentas are not in that area. So that's the benefit of this definition. So anything that is less than 28 weeks would normally manage those patients as a threatened miscarriage, because usually they come bleeding, because the time of formation of the lower uterine segment is the time the bleeding starts in these patients at risk of ending up with placenta previa. So that's why we stick to that definition of placenta previa should only be diagnosed after we've reached 28 weeks, which is the age of fetal viability in our setup. So when a patient comes in with placenta previa, there are several things we have to look at to help us in managing the patient. The first thing we have to look at is the bleeding. How is it? The second one is the hemodynamic status of the patient. We have to look at the gestation age. And we also have to look at whether they're in labor or not. So we'll look at each of these points in turn. So the first thing we have to look at when we have a patient in front of us with placenta previa is the bleeding, whether they are bleeding or not. And if they are bleeding, is this a torrential bleed or a non-torrential bleed? When a patient has a torrential bleed, the management is really clear. You have to deliver this patient. You prepare the patient for theater. You call the most experienced anesthetist. You call the most experienced surgeon, because this cesarean section is going to be a difficult one. They might need a vertical abdominal incision, a vertical uterine incision. This patient might need a hysterectomy. This patient might need a B-Lynch. This patient might need uterine artery ligation. This patient might need sutures around the uterine or is it the placental implantation site. So there are so many things that could go wrong in this patient. So we have to have the most experienced surgeon within theater. We have to have the most experienced anesthetist within theater, because of this bleeding. So that's the first thing. Then sometimes the bleeding has happened, but the patient is hemodynamically stable. We need to be very, very careful about these patients. We need to separate hemodynamic stability from a torrential bleed. If somebody has had the torrential bleed, their bed is wet, their all clothes are wet, they've bled, we have to deliver these patients despite um, their hemodynamic status. Of course, when a patient has poor hemodynamic status, they have to be delivered. It's that patient who has bled but has like a normal hemodynamic status. It's that patient that we really have to be careful about and have to deliver. The only patients that we want to manage conservatively are those patients that have not bled a lot and they are hemodynamically stable. So both things need to be fulfilled. The bleeding that they had was not torrential and they are hemodynamically stable. If those two are fulfilled, this patient can be monitored, admitted in the ward, monitored day by day. We keep the surveillance until we try to get this patient to term for the sake of the fetus. So that's the only patient that gets to be managed conservatively. The one who has had a non-torrential bleed and the one who has had who's hemodynamically stable. So the other thing we have to look at when we are deciding delivery is the gestation age of the pregnancy. So it should be clear that if the pregnancy is term, this patient has to be delivered as soon as possible. There's nothing that we are waiting for. We are just going to put the patient at risk of bleeding. The risk of bleeding at 38 weeks is about 60%. The risk of bleeding at 36 weeks is about 15%. So we don't want to increase the risk of bleeding for these patients. If a patient is preterm, on the other hand, we need to just make sure that they have not had a torrential bleed and they are not hemodynamically unstable. If those two situations are fulfilled, all we have to do is just manage the patient conservatively, week by week, and try to get them to 37 weeks. Once we get to 37 weeks, we deliver the patient. Then the other thing to consider is whether the patient is in labor or not. Of course, if the patient is in labor and we have a confirmed diagnosis of placenta previa, this is an emergency. Labor causes uterine contractions. There's a placenta in the way of the fetus. This patient is not going to deliver. They need to go for C-section. So if they're in labor, things are clear, regardless of the gestation age, regardless of anything else. This patient needs to be prepared for cesarean section. There's a patient, on the other hand, who's probably in labor, is bleeding or not bleeding, but we are not sure about the diagnosis of placenta previa. So a patient just comes in with painless vaginal bleeding. They are in labor. We've examined them. They have features of placenta previa. We examine the abdomen. The abdomen is not irritable. It's not tender. It's not stiff. They don't have all those features of abruptio. They have features of placenta previa, and unfortunately, we don't have a scan, as happens in many facilities in the night, as happens in many facilities in the rural areas. There's no scan. So in this case, we know that we cannot do a vaginal exam on the ward. We need to do what is called a double setup. We get two individuals, two surgeons, to go into theater. One is scrubbed, and the other one does a vaginal exam with a patient already draped. So the vaginal exam is done. Everyone else is scrubbed. The anesthetist is ready. A vaginal exam is done. When it's found that it's placenta previa, then the patient undergoes the cesarean section. We do this because we do not want to lose time. If you do this on the ward, then you do a vaginal exam, then the patient bleeds, then you start running around informing the anesthetist, informing the theater team. You find that you lose time and the patient can get compromised and die in this situation. So it's important that if a vaginal exam is going to be done in a patient with placenta previa that is not yet confirmed, maybe it's the bleeding, whatever has made us think of placenta previa, and we want to do a vaginal exam, and it's not possible to do an ultrasound scan to confirm the diagnosis, we do this double setup situation in a theater setup to avoid losing time in managing this particular patient in case they bleed after the vaginal exam. So this is just similar to what I've been talking about. So when we have a patient who has a placenta previa, then they're not bleeding at all, or their bleeding is something that can be watched. We need to do what is called a delivery plan. So when you're asked in the exam, we give a scenario of, or when you're on the ward with a patient, you have to do this. You have to write a delivery plan. You have to write a delivery plan for this placenta previa patient. So you have a patient with placenta previa at 28 weeks. Write a delivery plan. So this is generally what we write. We write the name of the patient, we write their diagnosis. Usually we write it in red on a big paper, then we stick it on the front of the file. So you write the diagnosis, so maybe it's major placenta previa or minor placenta previa, and so on. And then you have to sign. If you are the one who wrote the plan, you have to write the date of the plan. Then you have to write on the file when you are going to do the C-section. It's really advised that C-sections are done between 36 to 37 weeks, because the idea there is that the baby is almost term. So what are you waiting for? Are you waiting for a bleed? We know that as the pregnancy progresses, the risk of bleeding goes high. The risk of bleeding around 35 weeks is about 5%. The risk of bleeding goes up to 15% by 36 weeks, and it goes up to 60% by the time the patient reaches 38 weeks. So we don't need to prolong this delivery. Of course, we know that elective scissors are advised to be done at full term, which is around 39 weeks, but for placenta previa we need to do that early because of this risk of bleeding. So we do it early term. So that's 37 weeks. That's the like kind of the ideal time to do this cesarean section, because we don't want to wait for a bleed. Secondly, we do not just say that we are going to do this Caesar at 37 weeks. We need to write the date. When does that 37 weeks come up? So we know how to verify dates. We know how to use that early scan to know the dates. Then we give this mother the actual date this cesarean section is going to be. If nothing changes, if everything remains stable, we give her an exact date. So we write that your cesarean section will be on 25th December 2022 or 2023 or whatever year it is. We need to write that in black and white on our delivery plan, so that the mother is clear and people don't keep changing the goalposts depending on what is going on. So that is important for the mother, that's important for the team. Then we need to counsel the mother about what placenta previa is, that the placenta is in the lower uterine segment, that lower uterine segment poorly contracts, and when she delivers, the placenta gets detached from that lower uterine segment, she's going to very likely bleed, and she needs to expect postpartum hemorrhage, and we are going to do everything possible to prevent her from bleeding after she delivers, and that she has a risk of getting a hysterectomy from the bleeding. So that information is very important for the mother to prepare, to talk to her partner, to talk to her relatives, whoever she would like to talk to our friends, and so on and so forth. So this is important for the preparation, other than a patient coming from theater with a hysterectomy, which was never mentioned. So that should be looked at. Then we need to tell the patient to inform the nurses when she has any bleed, because she's on the ward and she's very likely going to be on the ward for a long time, especially if we admit them around 28 weeks, 29 weeks, because most of these placenta previa patients are diagnosed during the time that the lower uterine segment is forming, because the uterus is stretching and it's as the uterus stretches, it tears some of the blood vessels that are attached to it with the uterus. So that's when the bleeding starts. So we need to ask the patients to inform the nurses every time there's a bleed, even spotting. They should report. They should report how many pads they've changed every day, so that we track the amount of bleeding that this patient is having, so that it helps us make decisions on what we are going to do afterwards. Then on the delivery plan, we need to indicate who will do the cesarean section. So this is also important because most patients are taken care of. If it's a small hospital, of course, there will be maybe one doctor. If it's a big hospital, there are many units. So we need to know. And the important thing about who will do the C-section is that we need to have the most experienced people in doing the C-section. This is because the cesarean section for placenta previa can be quite difficult, especially if you have a transverse lie with placenta previa, or when you have an anterior placenta, because the placenta can be low-lying but it's anterior or it's posterior. When it's anterior, usually it means that you cut through the placenta when you're trying to deliver the baby. So we need a fast surgeon. We need somebody who can do a hysterectomy in case of bleeding. We need somebody who knows that if you cut through the placenta, immediately you extract the baby. You have to clamp the cord, because the bleeding, the baby will continue bleeding. So all those things are important. We need to get an experienced anesthetist, somebody who knows what to do when the patient is pouring, not somebody who will call someone else when the patient is pouring. We need to have that anesthetist within the theater as we do this procedure. That's about anesthesia. The other thing about anesthesia is that generally, if it's a stable patient, what the anesthesia advised is spinal anesthesia. But we know that patients who are under spinal have hypotension, and if this patient bleeds, then we are in trouble. So it's important to have somebody who knows what they're doing, somebody who can easily convert from spinal to general in case we have that trouble. And of course, the patient should also know about all these troubles that we've described. Then there are these routine things that we need to do for patients with placenta previa that are waiting to be delivered. So maybe they've been admitted at 28 weeks, they are waiting to be delivered at 37 weeks. So for these patients, we do cross-match weekly. Normally a labor ward will have a fridge where we keep this blood for these patients with placenta previa. When they bleed, then blood is readily available. You don't have to run around, and you keep changing these units weekly because they become old and they can expire. So you keep changing these units every week for those patients. For patients below 36 weeks, you need to give dexamethasone. We know we give 6 milligrams 12 hourly for 48 hours. So dexamethasone is important. For the rhesus negative patients, anti-D is important. If they are anemic, and most of our patients are anemic, we need to make sure we optimize the treatment of anemia. Vitamin C, ferrous sulfate, a proper diet. We optimize the amount of blood for these patients, because PPH, postpartum hemorrhage, is definitely coming for these patients. They'll be having frequent bleeds on and off. If it's not torrential, they'll always be on the ward. So we need to individualize the repeat for HBs. They might need HBs every 2 weeks, every week, depending on the particular patient and the amount of bleeding they are having. Then we do not need to forget the usual things we do for antenatal patients, because most of these patients will be on a ward for a month. So we need to know if they had their malaria prophylaxis, they are on hematinics every day, have they got their tetanus toxoid, have they had their HIV test, have they had their syphilis test, all those things that we do for patients who are antenatal and they are coming to our usual antenatal clinic. We need not to forget those things for these patients who are staying for a long time on the ward. Yeah, then we need to indicate on the file what we want to happen in case the patient bleeds. Sometimes we say for any bleed, this patient should be delivered. Sometimes we say if there's a torrential bleed, the patient should be delivered. And of course, if there's labor, we can tell whoever is available at that time that they shouldn't try to give tocolytics and so on. We tell them because we know what's going on. So we can say, well, if labor starts, please just take for emergency cesarean section. I was just mentioning in the previous point that of course, the delivery plan is a living document. You keep changing the delivery plan depending on where you are. So if a patient has received dexamethasone, you mark it, and if she's been bleeding on and off, you might change a few and just say, for any bleed, please deliver the patient. When your previous notes, delivery plan had said, please only deliver for torrential bleed. But depending on what's going on, how the baby is growing, what you are experiencing with the patient, you can change the delivery plan and just say, in case of any bleed, please deliver the patient, and so on and so forth. So that is important to do. The other things for these long stay patients, we need to do an assessment of the risk of DVT, and they would need thromboprophylaxis. So keep them mobile, keep them well hydrated, and so on. So we need to think about that, but it's a risky thing for giving things like our heparins for patients who have a potential of bleeding like this. But when you are pushed against the wall, you have a patient with placenta previa and they need thromboprophylaxis, then you need to choose between low molecular heparin and unfractionated heparin, because we know that low molecular weight heparin gives you a low risk of bleeding, but we also know that unfractionated heparin, you can easily reverse the effects if there's bleed with protamine sulfate. So we always need to put those things in mind when we think about thromboprophylaxis in patients with placenta previa. And lastly, I just wanted to briefly talk about home management of patients with placenta previa. This is something that we rarely do. I think we do this for patients with low-lying placenta and not patients with placenta previa. So patients who have low-lying placenta, that might be covering the os, but this patient is below 28 weeks. These patients usually, we can give in our setup a chance for home management, but everyone else above 28 weeks, all placenta previas, we just admit because we can't take the risk. We don't have blood, and so on. And if the patient comes bleeding, then we are stuck. So everyone above 28 weeks gets admitted. So that's one. And if we are going to do home management for a patient with a placenta previa, we would normally look at somebody who's never bled. That's important. Then we need to look at who's this person, the actual individual in front of us. So we need to individualize. So who are they? So I've put an example there that ideally you need somebody who's like a nurse, somebody who understands the condition, somebody who knows exactly what's going on, somebody who understands exactly the risk. You need to know who they live with in case they are pouring in the middle of the night. Is there someone with them? Is there always someone at home? Do they have a car? Do they have transport? Do they live near the hospital? What route do they take when coming to the hospital? Is it that place which is having traffic jams? Because we've seen patients deliver on the way to the hospital in a taxi, in a car. So we have to think about all these things. So availability of transport is not enough. And also we need to make sure that we have a patient who's being managed at home who can accept blood. So now you have a patient who's being managed from home and they come bleeding and they can't accept blood. It just becomes a mess. So we all have to think about whether this patient accepts blood transfusions or not. And of course, when they are at home, people would write that they need pelvic rest. So no coitus, because coitus can provoke bleeding. That should be clearly explained to the patient if they are going to be managed at home with this condition. So there's so much to talk about with placenta previa, but that's what we could talk about today. Thank you so much for listening. We will see you in the next video.